Shirish, your approach to lipid profile, one thing that I tell patients, it's not really completely dependent on what they eat, that it really is a drug effect as well.
I think before I actually answer your question, something I want to emphasize is the demographics of these patients. So, average age of lung cancer is 71. The average age of ALK-positive lung cancers is about 50 to 55. I don't want a 90-year-old to get lung cancer, but I do feel that the impact of lung cancer, and I would say the treatment, in some ways is quite significant in this population. And I think that needs to be considered. These patients usually are in the prime of their life, they're working, they have a family to take care of. And it can sometimes get challenging to sort of balance that with managing the care or delivering the care that they need, and for them to sort of do the things that they need to do so that they're taking care of the cancer. And so coming to the lipid profile, I think you really try to understand what sort of the baseline status is, both from a history point of view as well as from the laboratory test point of view. So I definitely do a baseline cholesterol. And I actually do relatively frequent monitoring in the beginning. If not anything, just to emphasize the point to the patient that how critical this is, that we take care of this proactively rather than react to the cholesterol going up and then sort of instituting treatments. I also will try to talk to them about dietary interventions. In some patients where I have concerns, I don't think I do it in every patient. I may get a nutritionist involved right from the beginning about it. I also feel, and there are other side effects with lorlatinib, which I'm sure we'll discuss, like the cognitive effects, edema, and things like that. I also think this is a process. So with things like cytotoxic chemotherapy, you try to give the side effect profile in the beginning, you discuss them, they experience the side effects to a large degree reasonably immediately. Mm-hmm. What we are noticing with drugs like alectinib is that some of these things like fatigue and weight gain are occurring in the second, third year. So one needs to be mindful that yes, patients are doing well, but it is not a profile that starts with the introduction of the drug and stays constant. It's a profile of toxicity that actually changes over time. And so it is quite critical that you are, in your follow-up visits, you're asking those questions, because some patients may not volunteer that information. They may feel, well, that's their life because they have stage 4 lung cancer. And I think that it is important that we are sort of having that conversation as we keep going on. Yeah,
I check cholesterol pretty frequently as well. That can go from 0 to 100 pretty quickly.
Yes,
it's quite striking. But you mentioned, I think, some of the more relevant side effects. For the most part, that is a paper toxicity. It's not something that patients are noticing. But we can see edema and weight gain. And as you mentioned, once you get out past 3, 4, 5 years, maybe 1 in 4 is going to have severe, significant weight gain. Laura, we often think of a cancer diagnosis, we worry more about weight loss, but weight gain is a big problem, right?
Absolutely. It's certainly a unique toxicity, and it can have really significant psychological impact as well as a physical impact. It can totally change the way a patient feels about themselves. They may not recognize themselves. They look in the mirror, they feel like they are just a different person. And it can be really difficult. I do like to involve the nutritionists. We have great dietitians at Georgetown. We're very fortunate to help get involved there. But understanding that they're going to have to maybe modify their diet and exercise as tolerated, and to find that balance of what their new normal is. The thing about this drug is it makes you feel hungry all the time. And so trying to find a way to control that and manage it day to day. Again, this is a drug that is given for years, so the longer time goes on and you're gaining more and more weight, this is a chronic toxicity that patients need to learn to deal with.
And it's also important for the doctors to sort of pay attention to that, right?
Sure, yes.
Sometimes we can't really see sort of on the outside, but if we look at weight, which I will admit, sometimes in a busy clinic, you're looking at
Yeah,
blood pressure,
yeah,
right?
yeah.
And someone says, "Well, I think I've gained some weight." You look back at the weight and say, "Oh my gosh, we've gained 50 pounds," or so that is important to keep in mind to watch. Mary, any experience with sort of the weight gain aspect of things, or how it can affect people?
Yeah, and I think as Laura said, it's really important. It impacts on the patient's body image and how they see themselves, and of course how others view them as well. And I think helping them understand why they've gained the weight, and dietitian absolutely, exercise physiologist, I think giving them a tailor, giving them the opportunity to have this tailored program of exercise that's specific for them to help them try and lose some weight, but also give them some control over what the changes that is happening in their body. And I think I believe that any of those significant physical changes that are a result of the cancer treatment has an associated psychological impact, and I think it's really important to have that discussion and acknowledgement with the patient about what it. A question often to start the conversation with them is, how does this make you feel? And just then stay with them during that conversation and offer them some sensitivity and acknowledging that this is another new phase for them, because it is. And stepping with them through with what we can do to help them, and that's the way we would approach it.
I think that it's really important that you prepare patients as well. You do not want it to be a surprise. You want patients to think that something else is happening.
That's right.
Shirish, your experience with weight gain, and maybe also any role for GLP targeted drugs in there?
So absolutely, the weight gain portion, I think first of all I want to say there is now data coming out that in clinical trials it has not been as well recognized and reported that the percentage of patients that develop weight gain, even with drugs like alectinib, it's well known with lorlatinib, but even with drugs like alectinib, is much more than what we were aware of. I think traditionally our concern in lung cancer patients used to be weight loss, and I think that this is a completely different toxicity that we are seeing. I think the other issue is that I just want to briefly mention about exercise, because I think we have not traditionally been something that we have looked at nutrition sometimes from the point of view of weight loss, but we have consulted dietitians and nutritionists. I think exercise may play a bigger role, and I think it is something that needs to be further studied in ALK-positive lung cancers. It's sort of in a proactive basis, right, from or soon after their initial diagnosis, because I think it may have a role in terms of cholesterol, in terms of weight gain. I think in terms of fatigue that may be induced by this treatment. I just want to mention that at this year's ASCO, one of the major presentations was in colon cancer, in stage 2 and 3 colon cancer, where exercise seemed to reduce recurrence-free survival. Now, we don't have that data in ALK-positive lung cancer, but I do suspect, based on the toxicities we see, the length of time these patients can live, that this may be something that needs to be studied and understood. Coming to GLP-1 drugs, I mean, I can tell you that this is a commonly asked question, and a lot of patients actually are going ahead and, I shouldn't say a lot, but at least some patients are going ahead and trying them to help. And I've seen sort of, just in my experience, sort of mixed results. Some patients have really benefited, and some patients have not had as much success or benefit from these drugs. I just want to mention that there is very limited data, and this is one area that absolutely needs to be studied. I will say that a publication from a group at Netherlands led by Dr. Dingenmans, published in JCO, only 10 patients, but there was a suggestion that the concomitant administration of GLP-1 agonist with alectinib, that the drug levels were somewhat impacted. Now, is that something that is necessarily going to impact efficacy of alectinib, and how relevant this data is in a wider patient population remains to be seen. But I do think we need to watch these patients very carefully if they are going on GLP-1 agonist. When a patient asks me, I actually refer them to an endocrinologist, at least in our health system. Those are the ones who are prescribing these drugs most frequently, and prefer that I take their assistance in sort of guiding the patients on the use of these drugs. And I will say in patients who have been maybe now on a 3-month or a 4-month follow-up, I start to see them a little more frequently, just to be certain that we are not seeing any unexpected toxicities, monitoring them just clinically and lab-wise a little more frequently. But again, it's something that needs to be studied.